Care Committee will come to order. We do have a quorum. Good afternoon, members. When we scheduled this hearing last week, I actually debated, well, we were living in a whole different world then than we are today. And today, given what's happening on the Capitol lawn, there's still some peaceful protests. I debated on canceling this, but this topic of taking care of our seniors in their long-term care facilities, especially during COVID, time is of the essence. So I have said, no, we've got to march on with this committee hearing and try to find some solutions to the problems that we're having. We're going to continue to keep an eye on what's happening out on the Capitol lawn, because I know some staff is still working from the building because there's better internet there. But also, the Senate website is currently down. So if you're watching in the public right now, we received a bunch of written testimony from AARP, the Alzheimer's Association, the Long-Term Care Imperative. And members, you guys all have it in your packet, but if anyone out there would like to get it and the Senate site isn't back up by the time this committee meeting is over, you can contact Ms. Johnson, my committee administrator, and she will email these documents out to you. Also, members, you received the letter that I sent to Commissioner Malcolm and the department yesterday with several questions that I'm hoping that we can get coverage during our time today. Commissioner Malcolm did send over 24 slides that we will also post to that committee site when the website is back up, but the commissioner does have a hard stop here at 4 o'clock. So in the interest of time, I think we'll just dive right into some of the member questions. And what I want us to get out of this today is what can be some potential solutions? Is it universal testing, or is it separate care centers, dedicated recovery centers? Just keep jotting ideas down, and then at the end, maybe we can wrap it up with some ideas that we as a committee could have for some solutions. So I'm going to start it out. Commissioner Malcolm, I think you have the letter I sent yesterday too, I hope.
I actually don't, Madam Chair. I need somebody to send that to me.
All right, Ms. Johnson, can you send it over to the commissioner?
Or maybe one of my staff has it, that they can resend it. Somebody's got it over there, right? I know you do, because we've been trying to pull data together to answer a lot of the questions, but I just don't have the letter itself.
Oh, okay. I'll just, and I know testifying here, you've got Marie Dotseth, Michelle Larson, and Chris Ersman also. So I'm just going to kind of roll through these questions. And members, if you have a question that pertains to the question that's at hand, just raise your hand and staff will alert me that you have a question that's on point. Yep.
Madam Chair, would you mind terribly if I just shared one very important piece of data that I hope is helpful to the committee on the subject of what percentage of our cases are in nursing homes versus other forms of long-term care versus the national average.
Sure.
The CMS just came out with data yesterday.
Yep, we have, and actually, members, that is in your packet also, the CMS data that came out yesterday and the map. So actually, let's just start off right there, because that is kind of one of the first questions. We'll just do the CMS data, Commissioner Malcolm, and then we'll go into the rest of these questions. So Commissioner Malcolm, if you can share your screen, I think. Oh, you don't have a screen.
Madam Chair. Oh, apologies, Commissioner Malcolm. I can pull up the CMS document in a moment.
Well, okay, I know our time is short and technology is not helping today. I went to the Capitol thinking the internet would be better, and it wasn't. So best laid plans. I think this question of, do we have something, really different going on in Minnesota than other states? We've been saying, but now we have data that kind of confirms what our theory is. We've been taking a very inclusive look at congregate care settings, not only skilled nursing facilities, but also assisted living those two certainly being what we think of as residential long-term care most often, but we are also including in our statistics adult foster care, group homes, mental health and substance abuse treatments, hospices, state-operated facilities. So, I think that's very relevant. So our theory all along has been that what we were being compared to was our comprehensive number of congregate care, which has been around 80% of all COVID deaths, was being compared to skilled nursing facility only data from most other states. And that's what the CMS data does confirm. The CMS data, which just came out yesterday, and again, I think important to remember, there have been no national reporting standards on this until CMS in April issued a requirement that all skilled nursing facilities start reporting data on cases and deaths. So that just came out in April. They didn't even send a standardized template for reporting. It was just report your cases and report your deaths, but no kind of definitions of what to count and what not to count. So there still may be some variability in the numbers. Be that as it may, the CMS data shows that the average number of nursing home cases per 1,000 is 62. Minnesota is 39.9%, so 40 out of 1,000, so significantly lower than the average number of nursing home cases in the US. The average number of nursing home deaths per 1,000, according to CMS, nationally, 27.5 deaths per 1,000. Minnesota, 12.7 deaths per 1,000. So it's just good to have more of a, kind of a consistent, or at least more consistent data set to compare. If we're just comparing skilled nursing facilities to skilled nursing facilities, that's how we look. I don't offer that in any way to say there aren't important issues around making sure we're doing everything we can to manage outbreaks in long-term care settings, whether those are skilled nursing, assisted living, or any other congregate settings. We know that those are environments in which both residents and staff are at higher risk just by the very nature of the setting. So, what we hope to do is give you a progress report on what we've done and what results we think we're seeing from the focus that we've had since the beginning of the epidemic, but especially since we have been working under this kind of specific 5-point plan that we announced, I think it was just about a month ago. But thank you for letting me just lay that data out there, because it's the narrative that's emerged has been not accurate. Again, which is not to say there aren't real important issues about, are we doing as well as we can? How can we do better? Because we completely agree, and we've been working hard to try to harvest all the lessons we've learned in the last 2 months to make a more systematic and stronger approach here. So thanks for letting me start there.
No, thank you so much, Commissioner. And to that point, we have always in Minnesota done our numbers differently, and it is nice to see that it's not apples to apples, being that the CMS just has the nursing home data and you were including all of the other congregate care settings. Is there any push to get nationwide data on the same apples to apples on the numbers that we're reporting?
I don't believe so, since CMS has only asked for skilled nursing facility data. So I think different organizations are trying to collect and ask for data on other settings, but there's no national that I'm aware of anyway. There's no national push to take a broader look.
Thank you, but I guess we still have that issue that 2/3 of our deaths here in Minnesota are happening in long-term care facilities, and that's what we've kind of got to drill down on here in this committee is how can we fix that? What can we do better? All of the states around us are doing better. Iowa, Wisconsin, North Dakota, even Nebraska are doing better.
Madam Chair, I'm not sure that's the case, just given what we just talked about. the percentage of deaths associated with a more inclusive definition of congregate care is what's pushing our rate up to that level. If we're only looking at nursing homes, it's 54%.
No, that is nursing homes to nursing homes. Nursing homes, the same exact data from the CMS thing they just released yesterday. But anyway, we'll move on.
I see.
Yeah.
Okay.
So first question is the rates of recovery, both in raw numbers and as a percentage from COVID-19 for the following demographics in Minnesota. What are the healthcare workers in long-term care settings? And what are the residents of nursing facilities and residents of assisted living? So what's the rate of recovery?
I'm not sure that we've had time to pull that since 4 o'clock yesterday, but maybe. Chris Erzman always surprises me by how much data she has. And but Chris, I don't know if you've had time to pull that.
We don't actually have that kind of data in terms of if someone has recovered, because we're looking at we're just looking at 14 days. We don't look at recovery, we look at removed from isolation. So we would just be looking at those individuals who were still alive after they were removed from isolation. So we didn't have, of your question, Senator Housley, we did not have that information.
Thank you, Senator Ralph. Did you have a question to that point?
Well, actually, I was more to the point of the percentage of deaths within congregate facilities versus the total deaths, and I think you kind of answered that. I am concerned about. I follow these numbers pretty closely, and I'm seeing some anomalies in the data, but I don't want to dive too deep on that. I've got another question down the road on some of this stuff, but I'll wait till we get down there.
Thank you, Senator Ralph. So Ms. Erzman, did you say that we can get that data?
We don't get recovery on any of our cases. We don't, what we look at or what we have reported out is removed or released from isolation, meaning that someone has passed the time when they would be infectious. But we don't call people back to say, how are you doing, or to be able to give a statement like recovery, because that has implications. And so we don't have that data.
Okay, so do you have the data for the number of COVID-19 deaths in nursing facilities and assisted living, with including the breakdowns among the following groups? The residents on hospice or palliative care in one group, residents with the do not resuscitate in another group, or where COVID-19 was not the primary cause of death, and where residents with underlying debilitating or life-threatening diseases, or residents with comorbidities.
We did look into that question that you had asked previously, Madam Chair. Chris, you want to talk through that?
Oh, it's fine if you want to, Commissioner. I wasn't sure if she was asking me or you, so.
Whoever wants to take it.
Why don't you talk it through?
Yep. Okay. So we do not have data on whether or not someone has an end of life decision. We looked at some broad research that suggested that, as people age, that many do make end of life choices or end of life decisions. One report looked at about 11% of individuals 75 and older had made that decision. So clearly not probably as many people as need to think about that, but we do have that sort of overarching information. And then you asked about deaths and underlying conditions. So when we look at underlying conditions, if we look at all of our congregate care settings, and where this is looking at the people who have died, 90% have an underlying health condition. If we divide that up by the various types of living settings, So in a skilled nursing facility, 90% of the deaths have an underlying health condition. Fewer than 1% do not. And then we have 9% where we're unable to say if they have an underlying health condition. For assisted living, 92% have an underlying health condition. Again, less than 1% do not, and 8% we don't have the information. In memory care, 79% have an underlying health condition, 3% do not, and in 18% of the cases, we don't have that data. In group homes, 96% have an underlying health condition, and there are 4% that we don't have data on, and then other, it's 56% of cases who have died have an underlying health condition, and 44% that we don't have information on. So that's the breakdown specific to the various settings.
To that, so if someone is admitted to the hospital, let's say an 82-year-old male with COVID, and he has a do not resuscitate, does he get released to a nursing facility that does have a COVID wing, and he passes away there with his DNR? That data then goes to that nursing home where he passed away, right? Even though he didn't get it there.
Correct. So in other words, when we are, and so this is where, the commissioners talked about being pretty inclusive. When we're describing COVID deaths, we're basing it on the person's place of residence. So in other words, are you living in a private residence? Are you living in a long-term care facility? And even if you acquired COVID at the hospital or you died at the hospital of COVID, that death gets reported in our aggregate numbers as a long-term care death.
How many COVID patients, COVID positive patients, have been discharged from hospitals and transferred to long-term care facilities since March?
We do not have that information. I'll defer to Michelle or Marie if they do, but we do not get that information.
Ms. Larson?
Madam Chair, we do not have that information.
Senator Ralph, to that point?
Well, I hit the wrong button. I guess my question relates to this point, but on a broader scale. And that is whether we've taken this same data that we're talking about and tried to in some way correlate between, first of all, long-term care facilities that have accepted these patients versus ones that haven't, and the rate of COVID growth in those two facilities, relatively speaking. And secondly, any type of analysis trying to determine if, in fact, releasing these patients into these homes has, in fact, led to an increase that would be greater than had they not been released in. I know that's a tough question, but I think it really gets to the point of what we're concerned with here, and that is it safe to release these people into the congregate care facilities? I think that's the bottom line question that at least I'm worried about. And if it isn't, then we should be examining this policy pretty carefully. If in fact, and I've talked to some of the long-term care provider associations and to some of the hospitals about it. And there's I think there's some other information out there that I really would like to drill down on. So thank you, Madam Chair.
Thank you, Senator Ralph. Commissioner Malcolm, you want that one?
Sure. Thank you, Senator. Well, I think, first it's important to say that there have been since the beginning some principles that need to exist for transfers from hospital to or transfers among facilities for that to make sense. I mean, we do believe that a skilled nursing facility is the right level of care for a lot of people leaving acute care. They've got the staff capabilities, they've got the expertise. In many cases, as we've talked about, it's these people returning to their homes, which they have a legal right to do. But that is conditioned on the ability of the facility to separate positive patients from or positive residents from others, to have either separate wings and they must have private rooms, private baths, etc. So there are some criteria that I think both the long-term care associations and we have agreed would be important and appropriate for that care to be safe and secure for the residents of the facility. Your questions are very interesting ones, and I'm fairly certain that we have not done that deep of an analysis. We will certainly, if we can get the specifics of your questions, if somebody hopefully wrote that all down, but if we can get that from you, Senator Ralph, we can take a look at how we might be able to dig into the data to look at that. What we don't have is evidence of on an individual case basis of transmission inside the facility from a patient who's come from the hospital, or at least that last week I was told that we did not have evidence of that type of transmission. But your question about is looking kind of from a data perspective on whether there's any difference in growth rates among facilities who've accepted those kind of transfers versus those who don't would be an interesting thing to look at. I don't believe we've done that, but again, I would ask Chris if that level of analysis has been done. I'm not expecting that it has, though.
To that point, Madam Chair.
Senator Ralph.
Thank you. I believe that in many cases that the people that I've talked to have said that they clearly have established protocols in terms of the state of the facility in terms of their being able to accept these patients. So I think that question is pretty relevant in terms of, yes, the hospitals will not release into a facility, or at least they're not supposed to release into a facility that doesn't meet those protocols and those standards. And that's why I think comparing between non-accepting facilities and accepting facilities might be an important inquiry. Thank you.
Thank you, Senator Ralph. I guess when it comes to all of this data, that doesn't mean anything to the families of a loved one that's in a long-term care facility and they're scared to death. And when they hear that COVID from the outside is coming into the facility where their family lives, data means absolutely nothing to them. Was it ever looked at like a flexibility from CMS that maybe we could keep these COVID-19 positive people in the hospitals longer, since there really isn't, there's enough hospital beds for them to stay there? Was it ever looked at for flexibility?
Senator Housley, this is Chris Erisman. Could I just make one comment?
Mm-hmm.
It's related to your question, but the data that we do have and have looked at suggests that staff have that the major source of bringing COVID into these facilities is staff who unwittingly have brought it in. So just wanted to sort of lay that on the table as sort of the overarching way that we feel that COVID has been transmitted in facilities, and then obviously once it's there, spread within the facility. So but not to, the commissioner can certainly answer your question.
Yeah, my apologies. I was on mute talking to myself there for a minute, but thank you, Chris, for jumping in. So on the question of, is there capacity to leave folks in the hospital? I think there's two questions. One, is there that kind of capacity? But secondly, as we know, staying in hospitals beyond the point when you need to be there is itself a risky thing. Healthcare acquired infections are a major source of problems in hospitals as well as in long-term care. So I think it serves a dual purpose, a multiple purpose, to get people out of the hospital as soon as they can get out. And again, part of it is their desire to return to their, to what is now their home. So, and that has been a really, not a small consideration in all of the planning efforts, is the role of individual choice and balancing that choice and that freedom with protection, protection for the person who's been ill, as well as for the others in the residence. But I just don't want to forget to mention that part. But so I think that the issue of trying to keep people in the hospital longer has not been something that we've had as a goal.
Thank you, Ms. Ayersman and Commissioner Malcolm. Which brings me to Ms. Ayersman, you brought up staff, and I do agree with you that it's coming from asymptomatic staff or symptomatic staff going between facilities, which brings us back to the universal testing. I've been a proponent of that since day one. Do you have the stats on what is the rate of testing happening right now in both the skilled nursing facilities and our assisted living facilities?
I do have that, Senator Housley, but I will pull it up and get back to you, just simply because I thought the commissioner was going to be giving a slide presentation and then you wanted to focus on the questions. So we do have that, and I will get it for you. And if you want to go to the next question, I'll just let you know when I have it.
Sure. So I actually just got a test yesterday, and they said it was approved by the FDA just yesterday. It was a fingerprint test that said, and I got it from a healthcare professional, and it was a $10 HERCOS test that you did a finger prick, and it showed if you had the antibodies or if you had active COVID. I'm just wondering, has that been FDA approved? Have you heard of any easier test than the nasal swab or anything that's out there, or was I scammed yesterday? I don't think I was, but because if that's true, that changes this whole questions going forward.
Madam Chair, this is Commissioner Malcolm. We're all interested in seeing what kind of more easier tests can be developed that not only have FDA approval, because frankly, the FDA approval, in the interest of just getting more testing into the market, they have not been using their normal process, and there's a wide range of sensitivity and accuracy in these tests. The specificity and sensitivity, two different measures, they're all over the place. So we're really relying heavily on, we've got a kind of a council of medical leadership from the health systems, along with folks from Mayo and the university, who are really helping to develop not just the testing criteria in Minnesota, but specifically what kinds of tests and what kind of situations give us the best information for clinical management and for population health. So it's so early on. It's kind of the Wild West in the testing regimen. I don't know if I personally don't know anything about the specific blood tests that you just took, but we do know that there's an awful lot of tests out there of varying accuracy, varying utility, and serology testing is really thought at this point in time not to be useful at the individual level for any clinical decisions because of the high rate of false negatives, I believe, is what the problem is with the serology test, and the fact that even having been exposed doesn't say anything about your current ability to be reinfected.
Thank you, Commissioner Malcolm. Ms. Arisman, were you ready? Do you have the rate of testing in the skilled nursing facilities or assisted living facilities?
Yes, so this is based on the the testing that's been part of the governor's 5-point plan. So to date, we have tested at 39 long-term care facilities across the state, including over 7,000 residents and staff. We have 30 facilities scheduled for testing this week, and we have identified, we asked facilities to reach out to us and if they were interested in testing, and we have 300 that have responded who have said that they want to move forward with testing, of which 127 responded that they have plans to do testing on their own. So in other words, the work that the National Guard is doing related to testing was really intended to jumpstart the process until contracts could be put in place with groups that could do the swabbing across the state. And so the National Guard has not been intended to be the sole tester, but just to let you know that that's what's been done thus far. And we have a number of facilities who are interested and intend to move forward on their own, as well as the ones that we are working to schedule.
Thank you, Ms. Arisman. What's the criteria that you are using to pick which of these facilities? If you have already 300 that are waiting and only 39 you're in 39 of them, what criteria do you use to pick those?
Initially, we have been focusing on those facilities that have at least one case. But the goal is, as you have indicated, that we would be able to offer testing at facilities that don't have cases. But right now, because we don't have infinite resources and the contracts had not yet been in place, we were focusing on those facilities that had at least one case. So a fairly low criteria, but we wanted to at least focus on the facilities that we knew that had a case. So that's where we've started.
And I think, Commissioner Malcolm.
I just was going to invite Assistant Commissioner Dotseth to jump in. I think she may have slightly more updated testing data than what Chris had. Maria, are you on?
Yeah.
Ms.
Sorry
Dotseth.
about. Yes, Madam Chair. Sorry, and I just as an indication of how rapidly this is all coming together and how rapidly we're getting facilities scheduled. Just as data that we just got, yesterday there were 19 more facilities tested and about 2,800 additional people, staff and residents. So we've got them scheduled now. As we ramped up, it was getting the facilities scheduled was challenging, but now that we have some lead time and people can prepare appropriately, we're getting more and more and more.
Thank you, Ms. Dotseth. I guess from the questions I've been asking and the answers I've been getting from the long-term care facilities and providers is most of them would do the testing all on their own, but it gets to be expensive. And they're currently asking their employees to go to their own doctor to get the test and put it on their own insurance. But now if you're going to be asking your employees to do this every week, to go to your own doctor at $150 a pop, are their health insurance premiums going to go up? So the staff is like, wait a second here, why should I have to be paying for all of this testing? And I think the facilities they're totally on board with doing universal testing for all of the staff, all of the residents, continue to do it on whatever timeline the department says, or the CDC. But who's going to pay for that? Like, part of me wants to say, yes, go ahead, go test everybody right now, and we'll get that money. But how can we pay for that for all of these facilities?
It's a great question, Madam Chair. This is Jan again, and we're trying to kind of map out the macro financing strategy as well. We know that a lot of the federal money that was just allocated specifically for testing, that's a source of funding for this. In addition to the money that was allocated for testing, there's a fair amount of money now coming from the feds into skilled nursing facilities specifically, much less help for assisted living. So we've prioritized assisted living grants in the funds that the legislature appropriated for us to use for healthcare providers to help them acquire, to help them do testing, to help them beef up staffing, to help them acquire equipment and PPE. So all that money that that you appropriated, some of that can be used for this purpose as well. But the federal funds, both in the last bill, in the CARES Act, as well as money that's reimbursable through the Federal Emergency Management Association reimbursement panel, we're exploring all of those ways to make sure we're maximizing every federal resource that we possibly can.
Thank you, Commissioner Malcolm. I don't know if you've seen it or if I sent it to you. I think I did, but I know that the governor has that $1.8 billion sitting there that's just for COVID relief. I do have a bill that special session I'm going to be bringing up that we do universal testing for all of our facilities and all of our staff and have it paid for out of that 1.8 billion. So I'm just giving you a heads up that I think this is our number one priority, and there's extreme urgency to get the staff tested, just to get residents and family members comfortable knowing that everybody is on some sort of weekly testing or whatever the schedule is, to make sure that that we get these people tested. And they can't not be testing because they don't have the funds. So I don't see a better place for 80% of the $1.8 billion to be going to, when 80% of our deaths are happening in our long-term care facilities or congregate settings. So I think that's got to be a top priority. But to that point, do you have a timeline on what's your goal date to get this universal testing done?
Well, to your point, Madam Chair, it will not ever be done. Just
right.
Given the desire to continue to do the repeat testing, as you said, we are, as Director Ayersman mentioned, we've been prioritizing those with a significant number of cases. A number of those cases, of those facilities with larger number of cases, are already doing have been universally tested and are doing point prevalence studies now on the frequency that the CDC and we have recommended. And Chris just told me a little bit earlier today that the good news is that the number of new cases being detected is going down in most of these facilities with each successive round of testing. So that's a good thing. In terms of plotting out the number of facilities, and again, we want to offer it to everyone eventually, but we want to get through those that have at least one case, and the numbers there are. Let me see. I think we had a slide on this. A lot of the data that you see on our website and that we report every day are cumulative numbers. So, for example, now we're back to the broad definition of long-term care of all congregate facilities. So we'd have to recalculate this data for you if you want it, and I'm guessing you probably do, on skilled nursing and assisted living in specific. But with the broader definition, 855 facilities have or have had at one time at least one case. So of that 855, half of them no longer have active cases. So we're down to 439 that have currently active cases. Then you want to kind of break that down into historically how many facilities have or have had only one or two cases ever and never went above that level, versus the number of facilities that have had three or more cases. So over time, cumulatively, well over half, close to 60%, of all the facilities have had only 1 or 2 cases, so not large outbreaks. 144, so 30% of the facilities that have ever had cases currently have active cases. 70% of them no longer have any cases. Of the 377 facilities that cumulatively since March have had more than 3 cases, that's where the focus needs to be. That's where the greater exposures certainly have been, and that's where there continue to be more active cases. So we're working hard to make sure that we're working intensively with those facilities to keep the case count from growing, and we are having some recent success in stopping the spread, even in those with more significant numbers of cases. But again, I mentioned that to kind of set the universe of how many facilities we really need to be testing pretty urgently because they have active cases. So that would be 430 something facilities that currently have active cases in them. So that would be kind of the priority, to make sure we're working through those. And so I think we, in terms of a schedule, and again, we offer testing to all of them. Some of them, are doing it on their own, as you've heard. And so we're just trying to facilitate for those who don't have the capacity to get it done on their own. That's where we're putting in the state support.
I understand what you're saying, but what I don't understand is we're 3 months into this and we're still trying to figure out testing finances. Meanwhile, caregivers are having their own staff use their own health insurance to pay for their testing. And how are we ever supposed to prevent another hotspot from happening if we don't have universal testing and we get it right now? So I guess what I really want to know is, there is urgency to this, and what is the timeline to make sure that everybody is being tested, not just the 39 facilities or the 7th up, but everybody has access to the test and everybody is getting tested, so we don't have any more of these deaths in our long-term care facilities.
Well, Madam Chair, I don't think realistically the goal is to prevent all cases, or sadly even all deaths. With the degree of community spread that we have, we know the priority of making sure that we are working with these facilities to make sure they've got good plans in place. Frankly, every one of them needs to be preparing for the eventuality that they will have cases, just by virtue of the degree of community spread that's out there. That I think is, I'm just trying to be really candid with the committee here. The question of, are the infection controls in place? Are we doing everything we can to give technical assistance and support to these facilities so that they've got good plans and they can execute the plans? Yeah, absolutely. I mean, and again, this is something we work with them on a whole range of infectious illnesses. I mean, COVID, of course, has got its unique challenges because it's novel. There's not good treatments and immunization and all the rest. But you're, I think, quite familiar with the statistics in long-term care on other infectious diseases as well. So I'm probably going a little off track here in my answer, but your point about universal testing, we agree with. I don't know that I think it's inappropriate. I don't think it's inappropriate for private insurance to be playing a role here. That's what we're asking. Pretty much the whole population to do is to go through their healthcare provider.
Madam Commissioner, we're not asking the employees at Target to use their private health insurance to go get tested routinely, because 82% of the deaths are at Target. We are asking those in our long-term care facilities, and it's hard for me to talk to a family member. My friend Joe hasn't seen his mom in almost 3 months because she's in everybody in the state that isn't allowed to see their loved ones. So they're now so frustrated, looking for not just a plan, and is the facility implementing a plan? Just get us universal testing. Let me see my mom. Let my mom have her hairdresser come in and do her hair. It's been 10 weeks. That's the plan and of course, we're always going to have deaths in our long-term care facilities and nursing homes, but we're talking about preventing these deaths and getting universal testing and getting families back with their loved ones. So I just wanted to make that point, that there's some real urgency to this, and already 3 months in, and it's still where it was in the beginning. Something has to change here quickly. Senator Abler.
Madam Chair, may I just respond to that quickly?
Sure. Go ahead, Commissioner.
My apologies, Senator Abler. I just we have to disagree that nothing's changed. That I think we're in a very different situation than we were. We know which facilities are having the issues. We know the ones that have resolved the issues. We've helped them do that. Where I think the universe of concern is getting much more focused, and we have a lot more resources that we are deploying against that. So I just wanted to just state that for the record. Thank you.
Thank you, Commissioner. Senator Abler.
Well, thank you. And I'm just going to go sit down here. I've been listening the best I can in between my office hours here. But so if I repeat a question, I just have like a comment, and then one question I asked before that I was waiting for an answer to. So my comment is this, Commissioner, I'm still a fan of John Malcolm, and I'm glad you're there. But I think if you judge from the tone of the questions that were posted ahead of time, the letters from anybody who's watching, there's a great deal of frustration and feeling powerless here as the briefings have gone on over the months. It's been kind of hard to access. It seems like people who asked hard questions maybe weren't invited back. And so you're probably seeing a lot of frustration from us, and I'll just speak for myself, from me in particular. And I think Senator Housley is as kind as she can be as she describes what she's talking about. And we're not seeing a lot of changes. But partly to me, that seems like it was slow on the uptake in the beginning. However, as massage therapists go back, there's a long list of things they have to do, which are very unreasonable in just even trying to do them. And so people have time to do that. I just confirmed with Commissioner Harpstead today that there's no guidance on PCAs, what they should do if they encounter a COVID house or they themselves have COVID. And I don't understand that. And so there's all this energy to make restaurants open at a minuscule way on outside, leaving hair salons locked up, who are actually experts in this. And the part that had the most need for focus still continues in a way that no one's satisfied with. And the last time we had a hearing, I asked a question, or actually I sent a question into the legislative question thing several weeks ago. And this is my question for this, and I could talk all day, but I won't. It's not respectful to the rest of the people's questions, but I'll just settle for this singular question. So how many places, facilities, group homes, whatever, are substandard with their infection control? And I was told I would get an answer, and it was weeks ago that I wrote this question and did not get an answer. And it was kind of based upon your comments at the last hearing we had, where you said we're not really where we want to be yet. So can you tell me where we are now, and how many facilities are like perfect, top-notch? In the paper, it talks about many places the troubles had histories of infection control in the past. So that'll be my one question for the day. So you can respond to my comments, Commissioner and my question, or just my question, whatever you like. So thank you very much for that.
Commissioner?
Madam Chair, Senator Abler, thanks. I think Michelle Larson is on the line. And if we don't have that, the answer to the percentage of inspections that have resulted in citations, we can get that for you, I think. And I think that's, if I translated your question correctly, we have completed infection control inspections on all skilled nursing facilities this spring. And that was a big big effort. That was, CMS really directed all skilled nursing facility inspections to focus on infection control specifically for this reason. We did issue, I know, some findings, but Michelle, do you happen to have that quantified? And if not, we can get it back to the senator.
Ms. Larson?
Chair, Senator. Hi, Madam Chair, Senator Abler. I was on Zoom and then I got kicked out, so I'm on the phone now. I apologize. My division does have this. I don't have that number exactly in front of me, and I apologize if I missed that question at the last hearing, but we can absolutely get that for you.
Yeah, and actually it was just a takeoff on the last hearing we had a month ago or so. And then there was a chance for legislators to ask questions like by email. And actually pretty much I've only gotten bounce back from you guys in the last 3 or 4 weeks. I figure maybe I'm on the list not to reply to, but at least it seems like that. You don't have a list? Okay. Well,
I don't have a list like that, no.
Okay, that's good to hear. But I'm just,
Senator,
I know you're busy.
You're not on any such list.
Okay, well, I know you're busy. But anyway, so the point of the question I think is really clear, is that there should be no facilities that are not up to snuff that are allowed to be open. And I actually, ironically, I did invite calling for the National Guard at that hearing. It's nice they're using their help how they can. And it's, never mind, I won't go into some of the training issues. And that what I was thinking about the National Guard was they could like clean the, like do menial tasks while people who had skill could do the skilled tasks. But so I would like to know how many places, not ones you cited, but how many when you walk in, like, this isn't right. Like you must have a 14-point checklist or something for things to do that are appropriate in infection control. And here in the very arena where people are actually dying, and most of them, and hardly anybody, no one's dying in restaurants or shoe stores or hair salons, by the way. I think I've discussed that in the past, but here where they actually are dying. And so that's what I want to know. And I think it's something that would be really on your list that you shouldn't need be to ask that question. So is it like, do you think 70% are up to speed? Do you think that 5% are bad? Can you just offer an opinion, and then I'll be happy to get that back from you.
I have data from a couple of weeks ago. If you want to just give me a minute and go on to the next question, I can pull that up for what I do have in front of me, and then follow up in a more robust answer on email. But if you just can give me a minute or two to pull up what I do have on our infection control visits that's broken down.
Yeah, I appreciate that. And Madam Chair, I think this is like the question to ask. I mean, if you're going to ask 4 questions as a Department of Health, like where is somebody not doing things safely? I think that's anyway. So I appreciate that. I'll look forward to the answer. That's all I have, Madam Chair.
Thank you, Senator Abler. I think it's a statement when we have over 500,000 people unemployed, including a number of healthcare workers in the state of Minnesota. Yet we still have so many job openings in long-term care. And I just feel that if we're going to be asking our healthcare staff to be paying for the tests on their own to get the COVID test, why would anybody even go into that? We already have a shortage of long-term care staff in these facilities, and that would just set them back even that much further. So I'm going to keep pushing for universal testing and a timeline, and that it gets paid for out of that $1.8 billion. I don't know if you have that information yet, Ms. Larson, or if you want me to go on to the next question. Or is that Chris Ayers?
Madam Chair, Madam Chair, this is Jan again. Just on your last point there, thank you. I don't think I was very clear when I was talking about utilizing insurance. We absolutely agree with you that the state needs to make sure there's no cost barriers to getting tests, and the insurers have agreed to waive copays on testing, as you probably know. And for anyone that isn't insured or somehow has faces a copay, that we absolutely intend to pay for that with public resources. So you can be assured that we're totally in agreement with you on the importance of not having an economic barrier to testing.
Thank you, Commissioner Malcolm. Is there a reason why MDH isn't requiring testing at all sites already?
Well, I think that the evidence, the guidance has changed over the months from CDC, and we've evolved our own guidance as the role of asymptomatic spread became more clear. Then a different kind of testing regimen does make sense. Early on, when that wasn't clear, that there's the utility of testing in the absence of symptoms was not clear and not thought to be useful, when we didn't know as much as we do now about asymptomatic spread. So and again, to the point of requiring versus offering, I don't know if we have any data on this. I'm sure we do. I don't have it at my fingertips, but of the facilities where we have gone out and offered universal testing, not everybody wants to be tested, and so we're not forcing people to be tested. So that's just also an issue of clarity, that offering and requiring are kind of two different things.
Thank you, Commissioner Malcolm. And to the last point on the health insurance companies waiving the copay, but have they committed to not increasing premiums? And we can take that offline and talk about it later. But that's again what the staff is worried about: is are their premiums going to be increased? And I know Senator Frentz and Senator Ralph, you've been waiting, so I'm going to go Frentz and then Ralph, and then we'll keep going. But I know, Commissioner, can you stay 5 more minutes?
Yeah, thank you. I'll just be a little bit late to my next meeting since I had trouble getting on in the first place. I appreciate your patience.
Thank you. Senator Frentz.
Thank you, Madam Chair. Thank you, Commissioner, for the work you're doing. I'm satisfied that you and your staff are working very hard and that you've saved a lot of Minnesotan lives. The question that you covered about universal testing, in St. Peter, in my district, the security hospital had no testing at first. And so could you say a little bit more about how decisions were made about where tests were performed and how your office made the decision about where you did and where you did not test? Thank you.
Commissioner?
Madam Chair, Senator, our major role is really to issue guidance to healthcare facilities about priorities for testing. They have all along kind of been making their own clinical judgments about testing, but we've given guidance about where are the priorities and why. And residents and staff of congregate care facilities have been high on our priority list since late March, when the first cases showed up. In terms of the security hospital, that would be a DHS decision, but we certainly have been, encouraging, whether it's in corrections or state-operated facilities, any congregate settings, to be getting more aggressive with testing, to have a lower threshold for screening, whether it's about testing or about isolation and quarantine, just really encouraging organizations to have a very low threshold, not saying, well, you have to have 5 out of 6 symptoms and you have to have a temperature of over 101. We've really been pushing for a much lower threshold of concern when it comes to screening for symptoms, both for the purpose of testing and for appropriately, asking people who are ill to to stay at home and to self-isolate.
Thank you very much, Commissioner. Thanks, Madam Chair.
Thanks, Senator French. Senator Ralph? We're going to move
Yeah.
on from testing then.
I have a question that kind of pivots off of that, but the first question I've asked, and that is, we're talking about using this money that we have. Have we made any estimates of the actual cost of doing this universal testing? I mean, you know, it's good to talk about it, but we need to know what it's going to cost and then figure out how we're going to pay with it. I mean, I think we should do it. I think it's very important to do it. I think it's very important to do it in not only the skilled facilities, but also the assisted living. And that does just, I'll raise the question now, and maybe we were going to get to it. But one of the things that I am getting from my, not only the individuals, but the organizations, and that is, testing is great. We have to do it, but we need PPEs. And there's been a very great amount of confusion as to how people in these individual facilities, number one, are supposed to be able to apply for it. Number two, what are the criteria? And so I'm very concerned about that we have this stockpile, and especially the assisted living, because my understanding is part of the criteria is what your prior use was in order to be allocated goods. Well, if you're in an assisted living, the chances of you obtaining PPE was probably nil. I mean, you didn't use them. So I guess I'm very concerned about how this whole system and who these people should talk to. I've never gotten a clear answer on how you apply for PPEs once you're about to run out. So if you could address that, if this is the appropriate time.
Senator Ralph, it is the appropriate time because that's right where I was going to pivot to, PPE. So Commissioner Malcolm?
Yeah, absolutely. Thanks, Madam Chair and Senator. I'm so glad you brought up the issue of personal protective equipment, because it is so critical to infection control, and it has been one of the risk factors and the weak links in the system is inadequate PPE to practice top-notch infection control. And we have been working on this issue, and it was really our urging, and we're grateful that the folks in the procurement team at the State Emergency Operations Center agreed to broaden their charge beyond acute care and to begin to procure with long-term care in mind. Marie Dotseth, I think, is still on the phone, and she can speak to kind of the request process. We have pushed out, as have the feds, quite a lot of PPE, not enough, I will be the first to say. And it's not always well matched to what an individual facility needs. So we're working on improving that ordering process. But Marie, can you speak to what the process is and we're changing?
Yeah, thank you very much. Thank you very much, Commissioner Malcolm, Senator Chair Housley, and Senator Ralph. So the process for asking for PPE from the state supplies is to work with the regional healthcare coalition. So there's 8 regional healthcare coalitions around the state, and those are comprised of healthcare facilities, hospitals and long-term care facilities, and local public health and local emergency management. And those structures have been in place now for about 20 years. And those structures have forms to fill out to make these requests for state supplied PPE. So that's the process. In addition to that, we meet with long-term care providers. I think we have regularly scheduled meetings, at least 4 different groups of them each week. And so we're really working hard to make those connections and make sure that everybody understands those processes that exist there in order to do things like ask for PPE. And you are correct that it's more challenging even for assisted living than some of our skilled nursing facilities, because a lot of times they haven't had the PPE in the past, so they don't have that private supply chain of PPE. And we also hear that's a problem. We've done pretty good, as Commissioner Malcolm mentioned, about getting some of that PPE both pushed out just proactively, and then also to respond to requests. And we know the federal government is doing the same. In May, there was over 200 million or 2 million gloves sent out, 37,000 cloth masks, 18,000 N95s, and 100,000 face masks and face shields. And so we've got to start on this, but we know that we need to do more, and we need to get it to where it's needed. We're also looking for places where where we can get them out to like emergency management, so that, or emergency transportation, so that if somebody urgently needs some PPE, that they can get it delivered right away to their facility. So we're exploring more options, and we have more to do.
Thank you, Ms. Erzman. Do you think that this lack of PPE, focusing on our hospitals, ended up us losing more lives in our long-term care facilities because they were not a priority? And if you still ask the staff at a lot of these facilities, they still don't feel like they're a priority. They feel like they're second fiddle to the hospitals. There's constant anxiety because their stack starts to get low. I feel like they really need to be prioritized when it comes to the PPE, because there's a lot of angst amongst the staff in the facilities.
Yep.
I have one question that somebody brought to me, that the state of epidemiologists determined that if an asymptomatic staff worker has been coming in caring for residents, tested positive, they've been told that they cannot continue to work, not even in that. So they have no symptoms, but they are COVID, but they're not even allowed to work in the COVID wing. Is that just I don't think that's the rules of the CDC. They say that symptomatic or asymptomatic staff members can work in the COVID wings, but here in Minnesota, they are not allowed. And again, staff is really tough in these places. So I don't know, can someone answer that?
Thanks, Madam Chair. This is Jan, and I will have to jump off after this question. I think I mentioned that we've had a CDC team in for several weeks, a couple weeks ago, to consult with us on these issues in specific, and we asked for another team to come back to continue the work. So we can certainly have a conversation about this. I'm aware that the group of geriatric physicians has recommended the same thing. Chris, I don't know if you know the current status of this recommendation. That I think that is correct, Madam Chair. That had been our recommendation previously, that any positive staff that tested positive should not be working in the facility. But I don't know if we have revisited that recently. But I think we absolutely can and will talk to CDC about it again.
Yes, Commissioner.
Chris, are you aware?
Commissioner Malcolm and Chair Housley. Yes, CDC has actually updated their guidance. Their recommendation is that if you're in a situation of crisis staffing, that then a positive healthcare worker who is asymptomatic could work on a COVID floor wearing PPE. And what we've tried to do is to make sure that facilities don't default to that. So it's not that it couldn't be done, but we asked to make sure that they've gone through a process to assess staffing, because obviously the whole reason that we're talking about universal testing, and the whole reason that we're talking about, the problem with what an asymptomatic transmission can do, is part of the reason why we want to be exceptionally cautious. Because even though these individuals would be assigned to a COVID wing, they are still in the facility. They don't parachute in just to that wing. So we want to be exceptionally judicious about the situations in which they can work. But there are situations in which they can work, but we have asked facilities, as I said, to make sure that they've gone through a process to really evaluate their staffing options, because as you've heard, we have been working to make sure that we try to provide them with additional staffing resources as possible. So it's a kind of a both and. Yes, there is some truth to that. The reason for that is wanting to make sure that we're not adding to the potential for transmission, but there are situations in which it can be appropriate, but we want to make sure that facilities, as I said, are going through a checklist, if you will, to make sure that they have looked at all their options before they reach that, because CDC's guidance is in a crisis situation.
So what I heard is, yes, they can have asymptomatic staffer as long as they've made sure that it's a crisis situation in staffing, which it is every day there. They can work in the COVID wing, is what I heard. What I want. Oh, go ahead. And then
well, I just right. We asked them to reach out to us when they're at that point so that we can kind of talk them through things. We want to make sure that these staff have appropriate PPE. There's just a number of things that we want to have in place. So I don't want to say I'm disagreeing with you, but I also want to make sure that we have the appropriate caveat so that there isn't the wrong message that, hey, go ahead and do this without being thoughtful. Because as we've talked about, I mean, our concern here is making sure that we're not increasing transmission.
I get that, but respectfully, Ms. Erzman, you heard Senator Abler. He never got his question answered. I still have been waiting for the data last week that I asked for, and I can only imagine if the facility lets you know, are they supposed to get your blessing to be able to do this? What's the process for that? We don't have that kind of time. So I'm just saying that what I heard is that they could, and they have to let you know, is what I think I heard.
Well, we're in contact with them practically on a daily basis. And so we want to make sure that we're working with them through the process. They have these COVID case managers that are assigned to them that work with them. And we ask that when they get to that point, that they are working with their case manager.
Thank you.
Madam Chair, this is Jan again. I do have to jump off now. I just want to thank you and thank the committee. I know how very much you are concerned about this and wanting to work with us to make improvements. Appreciate your questions. I apologize if we've not been timely in getting back to you on all of them. We'll try to circle around and see what questions you still have outstanding. And I look forward to the time when we can do this in person. It just feels a little harder virtually to make sure we're getting you what you need, but we will keep working on it. And thanks for your time, and I'll follow up with you.
Thank you, Commissioner Malcolm. I thought you'd already jumped off, so thank you so much.
Okay, thank you. Bye-bye.
Thank you. For those left, I just have a couple of questions that I'm hearing from constituents that have family members in there. The question is, isolation versus isolation. Their loved ones are in their room. They've been cooped up for almost 3 months now. Is there a plan in place to have some sort of safe, appropriate visitations that they can see their loved ones? And also to that point, is there any plan? I know this doesn't sound important, but it is extremely important to allow on-site beautician services, because now you're taking these people and you're bringing them off-site and then bringing them back in, and who knows who they've been exposed to off-site at their salon. Is there any plan to safely allow these services to be brought into the facilities?
Madam Chair, this is Marie Dotseth, Assistant Commissioner Dotseth. Yeah, we are, you might be aware that the CMS has published some guidance on safe reopening, and we are looking into that, looking to see, how will we know we are at that point? We know how terribly important it is to make it, to get to a point where we are able to safely reopen these facilities. And I know, and Michelle Larson might be able to say more, but I know that we have been really looking into a number of questions around beauty salons and safely making sure those services can be provided safely. So that is definitely something we're looking at. And I just cannot recall the latest email exchange on that issue, but yes, and I can get more information to you on what those CMS criteria, you probably have seen them, the CMS safe reopening criteria, but we're looking at those, and we're working with our long-term care providers on some of those meetings that we talked about. That's one of the things they want to work with us on.
Thank you, Ms. Dodd-Seth. I'm going to go back to universal testing on that one. I think even if they were a healthcare or a salon stylist in the facility, if they got the testing, that would alleviate that right there. I don't know, Ms. Larson, did you have anything to add to that? And then members, we have 6 more minutes if anybody has any questions.
Hi, Madam Chair. Am I off mute?
No, you're good.
Okay. We are working on that guidance as I speak. So we are working on the beautician guidance and outdoor visits right now. It's not ready yet. And we also use the CMS guidance to assist us with that.
Thank you. Members, I think.
Do you want me to follow up with Senator Abler's question regarding the infection control?
Yes.
Previous question that I didn't answer yet.
Oh, yeah.
So I'm just going to give Madam Chair, Senator Abler, I'm just going to give a high-level answer to that. And now that I know, I have you written down on my list. It's a good list of this particular question that I can go into more depth in. But and I hope you'll take an opportunity to look at the slide deck that the commissioner had for you, because we actually have done a lot of work. And some of the work in terms of infection control prevention visits that we've done not only for state licensed facilities, but for the federally licensed facilities. Just at a high level answer, about 70 to 80% of the facilities that we have gone out and either looked at in person or that we've contacted on the phone are in compliance with infection control. And you also have to keep in mind that we have a lot of facilities that really have less than 10 cases. So a lot of the bigger numbers that we're seeing are in the very large facilities, typically even in the more urban areas on many parts of the state. So, but I will follow up. We do have some of that more broken down that I think would help you understand to see what we're seeing out in the field.
And Madam Chair.
Mr. Senator Abler.
Yeah, thank you. And I appreciate that, but I hope you get the exclamation point behind my question. You are the people charged with telling us that our loved ones are going to be safe and that people are safe to actually, whatever you call it, admit people into those facilities. And so, 80% good means 20% are not okay. Curiously enough, just that same 82% number, 18% of the people are dying somewhere else. And that seems to be like a big deal. We're willing to shut down entire main streets, towns, industries, and watch people go out of business to try to address a couple of people in that 18% that might get sick. So I'm just telling you that in your own efforts, you're treating 20% as a really big number. I disagree with the way you've acted on the 18% part. But I think if a place is out of compliance, there should be a way that somebody should know that they're not complying with the very normal things that you expect them to do, just in terms of disclosure. And we've struggled with assisted living licensing and standards like that. But this is something people need to know, it seems to me. And so I know you probably don't need to put a skull and crossbones outside the door, but I think that people should know that there's a greater amount of risk because of some of the actions there. And sometimes they do all the right things and they just have a lot of bad fortune with the person coming in and, breathing on somebody at the wrong time. But I'll stop, but I'm just really surprised it's only 80%. So thank you, Madam Chair. And I really appreciate your work. I know you're having a hard task. And Senator Frantz, I could echo his comments. Thanks for trying. But this is the place we expect you all to excel at, especially since you're intervening in so many other areas that really aren't even risky. So I would say my final comment is spend all your time on the risky places and leave the rest go. Open the restaurants, let the hair salons do what they have to do. They're equipped, they're really good at sanitation efforts. Let them go and put all your efforts here where people actually are not going to die. Madam Chair, and thank you, Commissioner, I appreciate it.
Thank you, Senator Abler. Just while you were speaking, just so you know, Ms. Dodson, Larson, and Erisman, I don't know who said it, but we did, all the committee members did get the slides before the hearing. And I just went through them all, and I don't even see the 80% number on there on any of the slides. So I don't know where that is.
Madam Chair, this is Michelle Larson. We didn't add a slide on that specifically in this deck. I just was referencing that the slide deck gives information on the work that we are doing in long-term care. So I apologize I didn't mean to misrepresent that.
Okay, thank you, Ms. Larson. I was like, wait a second, I just looked at these and it's not on there. All right, members, I don't know if anybody else has any questions before we adjourn. I don't see any hands up. I do want to thank you, Ms. Dotseth, Larson, and Erisman. I'm sorry I'm not putting your titles in there. Thank you for getting us some of that information. I am going to send out, more detailed and bullet point of these questions and answers, and some of them that we didn't get answers to. I'm hoping that, well, I'm actually going to keep pushing that we have more progress in this, because I don't see that the needle has moved much at all in long-term care, and we still are at 82% of the people are dying in those facilities. A lot more work needs to be done. And so you're going to be hearing from me and this committee daily and publicly, because we really need to get some answers. We need some urgency to this, and we have to get universal testing, and we have to get it paid for. So to that, members, thank you. Thank you, Ms. Dotseth, Larson, and Erisman for coming, and thank you, Commissioner Malcolm. Thank you, members of the committee. We probably will have another one here, not before June 12th, or maybe, but I will keep you posted. I'll get everybody the document out on these questions and answers. So thank you very much. And with that, members, we are adjourned.